Hello everyone and welcome to this edition of the Podiatrist Digital. My name's Emma McConnachie and I'm from the communications team at the College of Podiatry. Today I am very happy to be joined by our CEO and General Secretary, Steve Jamieson. Now today we're going to be talking about HIV, and this is a topic that so many of our members have got in touch with us looking for some guidance. Now we will be having a full clinical piece in the July issue of the Podiatrist print edition, but today Steve has joined me to give us a little bit of background about the condition. Now some of you may know this, some of you may not, that Steve is actually a registered nurse, and he was formerly, and Steve's going to help me get this right here, a clinical specialist nurse in HIV. Yes. So I'm just going to get Steve to guide us a little bit through the history of the condition and management in the UK, and maybe give you a little bit of first-hand insider knowledge on what it's been like with the condition and how we as clinicians can help demystify the disease for ourselves as well. So thank you very much for joining us today, Steve. Would you like to give us just a little bit of background about yourself and your clinical background?
Sure. First of all, Emma, thank you so much for asking me to do this, and I'm really delighted to do it. As you rightly said, I was clinical nurse specialist for HIV, and I got into the HIV world really fairly early on in the whole epidemic. So I was early sort of 1985, 86 when I joined St Thomas's Hospital in London as my first ever charge nurse job. And that was on a HIV ward, and I say it was an HIV ward, but in fact in those days it was basically a corridor with some beds off the side of that corridor, because people didn't really know in the early 80s what this virus was all about. And in fact we were seeing lots of young men, and it was young men at that time, coming through our clinics with various symptoms, one being Kaposi sarcoma, which is a skin cancer, and another being pneumocystis carinii pneumonia, which was a pneumonia which really we hadn't seen around for years and years and years. And lots of these similar symptoms were coming through, and our guys were mainly young gay men at this time. And it was then that we realized that they were having lots of other blood disorders, etc., and that their prognosis was really quite poor. So in fact, in the early 1980s, I was dealing with young gay men who were dying of this condition. And as you can imagine, in those days, it was very much a taboo subject. The whole issue around sexual health was never really discussed. The whole issue about people being gay was never really discussed. And it's often brushed under the carpet. And I suppose one of the things that really stuck me was about how healthcare professionals treated those patients in those days. Obviously, people like myself, who was employed and really interested in the area of this whole virus, were working really hard. But actually, we had porters, we had people in other departments, we had domestics who would all refuse to come onto the ward to either transfer the patients for X-ray or to theatre or to another ward. Cleaners would refuse to clean the wards, and so it was really difficult, and the whole stigma attached to the virus was really quite rife at that time. We even had press who would dress up in doctors' white coats and come onto the ward to try and take photographs of the guys as they were dying of the virus. So yeah, and I became really more interested in what this virus was all about, and as we started to see the number of people with the virus growing all the time, I became more involved with HIV, and at the Royal College of Nursing they started up an HIV nursing forum, which I joined, and eventually became chair of that forum, and really just shaping the future of care for people diagnosed with HIV in those days. And so that's where my interest sort of started, and I developed my career really through HIV and sexual health. I was as I said, the chair of the HIV Nursing Forum, but I also became president of the European Association of Nurses in AIDS Care, and worked in other European countries for a while, and certainly in Poland and in Romania I worked in some children's hospices with young kids who were dying of the virus in those days. And so I was able to develop some really good nursing pathways and programs for caring for people with HIV. Now in this country there was obviously treatments available, but in places like Romania and Poland there were no treatments for those kids, and we were just basically caring for them without any medication as they were dying of the virus. So a really tough time, and as the condition developed, and as we got to know more about the virus, then obviously the treatments became better, and we were able to begin to treat people for those pneumonias and those skin cancers, etc. And what we did start to see then was people living a bit longer because they were being treated, but it wasn't a cure for the virus. And of course, there still isn't a cure for HIV. But what there is now is medication which can really help people and support them through having a normal, healthy life. And I know personally of a number of friends of mine who are currently HIV positive, but take one tablet a day now. So it's a bit like a long-term condition I class it as now, that we are caring for people who, like people with diabetes, for example, who take a medication each day, but can actually live a very well and healthy life. So I suppose for me, one of the sad bits about all of this is that if those treatments had been around in the early 80s, when we were caring for those young guys at the time, a lot of them would be alive today. So yeah, learned a lot, laughed a lot, cried a lot, and gained a lot of really good friends out of the work that we did, because we had to work together very closely as teams, especially in end-of-life care as well. It was so difficult. But yeah, great times, and I'm really happy to be able to share some of my thoughts moving forward on how we can support our profession of podiatry now in supporting and treating people with HIV as we move forward.
Yeah, I say it's really interesting to hear you speak about that, because that's something I personally have never had any experience of, in that, as podiatrists, we're not in that level of care in the same way. We tend to have a different pathway for going in. So it's I can only begin to imagine what that must have been like for you all, feeling so helpless that you couldn't fix all of that. And I too have friends that are HIV positive, and it's so nice that they can talk about it now and things as well. It's getting a bit less taboo for people to discuss. But even when I was training as a podiatrist, we got taught you double glove, you do all of these things, and there was this big stigma that was built up around it. And I think that's one of these things that we're starting to break down now, as the management gets easier for people, and it's so positive to see how it is today compared to what it was when you started noticing the disease coming to the fore.
Yes, sure. And I think one of the key things for me is about, we should be careful with every single patient that we care for and support and we treat, whether you're a podiatrist, a nurse, or a physio, whatever it is, you're carrying out safe clinical practices. And that's what needs to happen today. So, we have no idea of the number of patients that would come through our books, I guess, as podiatrists, unless patients actually disclose that they are HIV positive. You've no idea whether that patient is positive or not, just by looking at them. And so therefore, the key thing is about, carrying out safe clinical practice. If there are cuts, it's about using gloves, etc., that all of our members know what to do. But, it's about treating everybody the same, and when I look back at the stigma that was attached to HIV in those days, we have moved on so much, and because of treatments and because of the pressure of people living with the virus was actually able to be the advocates for the virus and begin to stand up and say, look, I'm just the same as a diabetic, I'm just the same as other people with long-term conditions, and this is the way I need to be treated. So yeah, it is about building up that rapport with our patients, and it's about, when they feel ready to be able to tell you or disclose their diagnosis, which in my experience nowadays, most people with HIV feel very comfortable about doing it, because a lot of the stigma has gone and the treatments are now out there and more readily available for them. So they are actually able more comfortable at actually discussing it with their professional podiatrists.
Yeah, because there's been quite a lot of changes in the management now as well, things with the antivirals and things. And what kind of differences have you noticed over the course of your career now?
I always remember when sort of antiretroviral treatments came out at first, that patients were on 30 and 40 tablets a day. And in those times, you used to have to set like a little alarm, which would go off when they were ready to take their next dose, because they couldn't, miss an hour without taking it. And so often patients' lives were just taken up by taking medication. So they couldn't go anywhere without taking piles of tablets with them. They had to be taken at the right time. They had to be taken either with food or without food. All of that type of thing, which really just ruled the day-to-day living of individuals. Whereas now, you know, as I said earlier, 1 tablet a day seems to be the most common treatment now for it. And so, you know, it has changed so much. And that one tablet a day treats and keeps the HIV antibodies so low that actually most people now are undetected from their antibody levels within HIV, which is just amazing. And it, you know, I guess it sort of it makes me sort of think about the days of HIV when we're now looking at COVID, because, you know, those days it was a pandemic. No one really knew what we were doing. No one really knew about the medications. And actually quite quickly the scientists took on board what they needed to do. And, you know, if you look at what's happened in a year with COVID, it took sort of 20 years for that to happen in HIV care. And as I said earlier, a lot of those people would still be alive today if we'd have had those medications. So for me, the difference is that the medication doesn't rule the person's life anymore. You know, it's the individual living with the virus that's in control of their own treatments from now on, which is great.
I mean, as a clinician now, what kind of advice would you give to our members for things to look out for, or things to look at when they're looking at managing a patient who does have an HIV positive status?
You know, one of the key things, and I've said this before about podiatrists often have the luxury of spending a good 20 minutes, half an hour on a one-to-one with their patients. And, you know, and if the same patient is coming in, and if you're on a regular basis to see that podiatrist, it's about building up that relationship. And the person may not feel comfortable right at the very first assessment about telling of their HIV diagnosis, but as they build up that relationship, they'll often share it with you. And I think it's about not looking surprised or not going, oh my God, you know, what happens if I get it? Because that's not going to be the case. And B, it's about, you know, just looking and observing the skin of people with HIV, because they, like others, will have, you know, small skin lesions or things that are happening which, you know, may not be HIV related, but may, you know, need some sort of specific treatments. And so it's always, I guess, in the back of your mind, as you are with any patient and a podiatrist, that you know, you look at the various types of presenting conditions and work out, you know, what is the cause for each one of those and how you treat. But, you know, it goes back to the whole thing that I was saying earlier. This is about safe clinical practice, and this is about making sure that the people that you're caring for are cared for safely, that you as an individual practitioner are safe within your own practice, and that your patients feel comfortable enough to be able to share with you their diagnosis. My experience, certainly over the past few years, is that people living with HIV nowadays are very happy to talk about their condition, and, you know, it doesn't have that taboo subject that has been around for years. And so hopefully they are able to open up to you. And I guess for you as a podiatrist, it's just having that in the back of your mind when you're caring for them, because they may still have some sort of blood disorder, or they may have some bleeding disorder, or they may have some small lesions on their skin, which are probably not HIV related, but it's always worthwhile thinking about it and then knowing where you can refer on to if you need to.
Yeah, I think as well, as we all know, with the management of patients with long-term chronic conditions, the patient themselves is always a great resource. They know what their levels are, they know what their boundaries are, and they'd most likely have a specialist nurse that's available for any specific questions about, for example, if we needed to do a nail avulsion, or, you know, there's a specific treatment that we might be carrying out, no different to the dental work. They've probably got examples that have already been given by their specialist nurse, and they know what questions to ask. So, I mean, I know my own clinic, I'd be speaking to the patient about what their own levels and things are as well. But in the event that you've got, you know, you maybe know that you've got a patient coming in, and you might be maybe a little bit embarrassed to have that conversation with the patient. You don't want them to realise that you don't know everything just yet. Have you got any tips that you would give for where clinicians could go to get a little bit more information, other than, of course, our upcoming issue of the podiatrist?
Of course, no. I hope that our edition of podiatrists will cover a lot of that. But you know, there are lots of HIV sexual health services out there that are really brilliant, and I've got some brilliant literature for all different healthcare professionals to read. So, you know, if you know that you've got a patient who is HIV positive or has an AIDS diagnosis, even, it's really important that you know you get as much information for you as the practitioner as well. So sexual health centres attached to hospitals or to clinics are really brilliant, and a lot of the information, a lot of the advice, a lot of the literature that they've got is really up to date, and it's free. So you know you could quite easily phone them up and say, I've got an HIV patient that I'm caring for. What information have you got that would really help me as a podiatrist, and get them to send it to you. And you know, as we all do right now, there's lots of stuff on the website. So you know, Terence Higgins Trust, any of the sexual health services that are out there have got lots of stuff on their website, and it is really important to read up, because things change all the time. It's a bit like our COVID vaccinations right now. You know, things are changing every day, and there may be new treatments coming on board. But Emma, you're absolutely right. The patients often know more than their nurses or their doctors, even, because they read up about it. They know every single symptom, every single treatment, every single issue related to their virus. And I think, you know, ask them as well. Be comfortable at asking the person with HIV, you know, have they found out a bit more about what that issue is or what the condition is and what's their thoughts on the treatments that are available. But never feel that you can't get the information, because it's all out there, and most of it today is on the websites of various sexual health clinics. But I often, you know, in my experience, was often just calling up the local sexual health centre where people would go for other sexual health related conditions as well, who've got tons of information, and they'll often just send out, you know, public health type leaflets on how to manage things. So, you know, I'd really make them sort of one of your key contacts.
Excellent. Well, thank you so much for taking the time out of your day to share a really interesting insight into the history of HIV and nursing. And I say it's great to have been able to have that insight as well, even from within our own organisation. Like I say, Steve's just given us some personal recollections today about his time with HIV management, but the July issue of The Podiatrist will feature a whole update all about HIV management, so please look out for your issue dropping, and thank you very much for joining us.